Good afternoon. My name is Eric Fung, and I'm the Senior Vice President of Clinical Development for Grail. And thank you for coming this afternoon to hear about multi-cancer early detection. Grail was founded in 2016 to take on one of the world's biggest public health talent challenges. It's headquartered in Silicon Valley, really the hub of life science and technology industries. And we've assembled a world-class team of leaders, scientists, clinicians, engineers, and other experts to form a cross-functional team to really solve a problem around cancer screening and the ability to reduce mortality from cancer by screening for multiple cancers at one time. Our company has been rapidly growing, and we're over 1,200 employees. Obviously, such a huge endeavor cannot be done alone, and we have partnered with many of the major institutions across the country and, in fact, across the world to really advance cancer screening and changing the way that we think about how we can detect cancer early. As everybody knows, there's a staggering human and economic toll from cancer. There are over 8 million years of lost lives. And in the United States, there are more than 600,000 deaths expected from cancer in 2022. There's a huge economic cost of cancer, anywhere from the workup to the treatment of cancer. And of course, there is a huge economic toll of the cancers that we don't screen for due to the mortality and morbidity from these cancers. Now, in the United States and elsewhere around the world, we have been thinking about how to solve for this problem. And there are guideline recommended screening, of course, but these programs for guideline recommended screening only account for about 3% of deaths. And of course, these are well-known cancer types such as breast cancer, colorectal cancer, cervical cancer, lung cancer for a very small proportion of individuals who meet those criteria for high-risk smoking. And so, in fact, the vast majority, about 70% of deaths, occur in cancers for which we do not have guideline recommended screening. And that is really the public health question that we're trying to address here. We obviously know that detecting cancer early can dramatically improve survival from cancer. And in fact, that there's an 89% survival rate when cancer is diagnosed early before it has spread, and a very poor survival, 21%, when cancer is diagnosed late. So at Grail, we have been thinking about this problem for some time, and we believe that we can do better. And the way we can do better is really changing the way we think about cancer screening. And instead of screening individuals for individual cancers, we can screen individuals for multiple cancers. And so if we can provide a test that can detect multiple cancers that are complementary to guideline recommended single cancer screening, and that can optimize what we call overall cancer detection in the population and minimize harms. And we'll talk a little bit today about that balance between harms and benefit of screening and where multi-cancer early detection, particularly because of the biology of the shared cancer signal that we detect, can really help us achieve an optimal balance of benefits and harm ratio. Grail fundamentally is a science-driven company. And so really the test that we have developed mirrors the scientific findings that we have had along the way to where we are today. And where we began was really an insight from non-invasive prenatal testing. As you know, non-invasive prenatal testing looks for cell-free nucleic acid that's circulating in the blood, and tries to identify trisomies. In a large cohort of women who are undergoing non-invasive prenatal testing, a very small proportion of those women had aberrant signals that were clearly not trisomies. And in fact, those were found to be representative cancer. And so you can see that there were 10 cancer cases found in over 125,000 NIPT tests. And what this told us was, first of all, that we could identify a cancer signal from cell-free nucleic acid in blood. And second of all, very importantly, that there's a shared cancer signal, because we were not looking for a single cancer. We were not, in fact, looking for any type of cancer. And yet this shared cancer signal was present in that circulating DNA. And this is a foundational principle that has helped us achieve the clinical performance that we have been able to demonstrate for multi-cancer early detection. So the biological implications for MCED testing from these early findings really have told us about how we should think about multi-cancer early detection. First of all, we know that an individual, any individual, is at measurable risk for developing cancer in any organ or tissue. Many cancer types shed tumor DNA into plasma, and that in fact, these cancer-specific methylation patterns are shared across multiple cancer types. These three principles were demonstrated in those NIPT studies that I just described to you. And what that tells us is that at a population screening level, there'll be many different kinds of cancers that are identified using cell-free DNA, and that many of these cancers will be ones that we do not screen for. Another guiding principle that we have learned through many of our studies that we have conducted, as well as others, is that methylation patterns reflect ancestral cell and oncogenesis selective pressures. What that tells us is that we can look at various types of methylation signals that can help us understand where that cancer has come from. And by providing this information to physicians, they can better tailor the type of workup that they should do in working up this common cancer signal in any given individual. And we'll talk about this in greater detail as we continue in this presentation. As we think about the principles of changing the paradigm of cancer screening from single cancer screening that is done by one to a multi-cancer early detection test, we have to rethink the way that we should deploy this test. Obviously, we want to develop a blood test that can detect multiple types of cancers, focusing on many unscreened cancers while complementing guideline recommended screening cancers. We want that test to be able to detect the cancers that we care about the most, i.e. the ones that have a high mortality. We also want to provide to physicians information that will help guide their diagnostic workup. Foundational, of course, is the demonstration of the performance of this test in large-scale clinical validation results. And finally, we want to have a high specificity. This high specificity, which is obviously conversely a low false positive rate, will allow us to deploy this at a population level without incurring too many unnecessary workups or other types of harms that might be related to population level screening. So as we indicated earlier, what we're measuring is cell-free nucleic acid. And the derivation of that cell-free nucleic acid in blood really is a consequence of tumor tissues that die or undergo apoptosis. And when that occurs, they release their aberrant DNA into the bloodstream. We can isolate that aberrant DNA and then measure that. As you know, there are many kinds of genomic alterations associated with cancer. Some of these are small nucleotide variants, such as mutations. Others are chromosomal alterations, such as copy number changes. And of course, you recall that is what NIPT has foundationally been utilized to measure. And then there are aberrations in DNA methylation patterns. In our early studies at Grail, we actually measured all three of these types of aberrations and focused on DNA methylation patterns as the aberration of interest for us to continue to pursue, because it was able to identify that shared common signal, as well as provide us with cancer signal origin information. Methylation patterns, of course, are well known to provide differentiation information. And so, in fact, the methylation patterns that occur in different organs will allow us to actually identify that original site of the cancer. And of course, the methylation patterns also tell us the distinction between cancer and non-cancer. And so, of course, we use machine learning to answer both of these questions, i.e., is there a shared cancer signal present? And then second, if so, where did that cancer signal likely originate from? We also know that cell-free DNA tumor fraction increases with stage. And in fact, this is essentially a universal principle across different kinds of cancer types. And here you can see a number of different cancer types, and you can see the tumor fraction on the y-axis as a function of stage on the x-axis. And you can see that increase as a function of stage. So we'll talk a little bit about specific performance characteristics of the Grail MCED test. But what we can do is we can ask ourselves, as I indicated in the opening of this presentation, what that might look like from a public health perspective. And so looking at the performance of the Grail MCED test applied to a modeled population, we can see that from a diagnostic yield perspective, we could intercept 31% of cancers using multi-cancer early detection. Of course, it's important for us to be able to detect these cancers earlier, and we can measure that by a reduction in late stage, i.e. stages 3 and 4 cancer incidence. And we can in fact see a 50% reduction in late stage incidence. And that is expected to lead to a mortality reduction. And of course, it is that reduction in mortality that is the ultimate goal of all screening programs. And so really what we think of is Grail MCED testing should complement guideline recommended screening, and together they will achieve an overall reduction in cancer-specific mortality. So I told you a little bit about the biology and what that biology has told us. I'd like to now turn to our clinical studies and how those clinical studies have demonstrated the value of MCED testing. At Grail, we've conducted a clinical development program that really thinks of this as a population health problem. And so you can see that our clinical study programs have in fact enrolled over 300,000 participants in aggregate. And additionally, we have designed different kinds of studies to represent the different types of information we're trying to learn from each of the study. We began our work with a case control study called CCGA, or the Circulating Cell-Free Genome Atlas study. This was really intended to develop and validate a cell-free DNA-based MCED test. We conducted 2 large cohort studies to provide us with information about the cancer distribution in 2 kinds of screening populations. In STRIVE, this was a population of women undergoing mammography. And so, of course, this is a mammography screening cohort. In SUMMIT, we enrolled a population that qualifies for guideline recommended low-dose CT screening. So this is a heavily smoking population. Now, of course, as this audience knows, smoking leads to an increased risk, not just of lung cancer, but of multiple types of cancers. And so it is a good population in which to evaluate how MCED testing can be utilized in a high-risk population for detecting multiple types of cancer. We have Pathfinder, and we'll talk much more detail about the Pathfinder results, but that was an implementation study of actual utilization of MCED testing. We have recently completed the first year of enrollment of NHS Galleri, a large 140,000 participant randomized control trial that will ultimately identify the clinical utility of MCED testing in a population. This study, of course, is done in collaboration with the National Health Service in the United Kingdom. We are now continually able to look at the performance of MCED testing and the utility of MCED testing in a real-world population. And Reflection is our real-world evidence study of looking at how Galleri testing, Grail's MCED test, can be utilized in actual clinical practice. Additionally, we have followed on Pathfinder with Pathfinder 2, which is a 20,000 participant study that is evaluating the MCED test performance in an eligible screening population, focusing particularly on a broader ethnic diversity. And then lastly, we have a program that is looking at how MCED testing can be utilized in a symptomatic population, because obviously symptoms can be indicative of the presence of cancer. So today we'll focus largely on our evidence from CCGA and Pathfinder. CCGA, as I indicated, is our case control cell-free, circulating cell-free genome atlas study, which was utilized to train and validate our classifiers. As I indicated earlier, our early studies were really intended to understand what type of analytes we should measure. And as we talked about earlier, aberrant genomes from cancer can have changes in methylation patterns, in single nucleotide variants, and in chromosomal alterations. So we actually measure all of these in our first cohort of CCGA participants. Those data told us that we should focus on methylation patterns because methylation patterns could identify that shared cancer signal, as well as provide us with cancer signal origin information. We utilize CCGA to refine our methylation machine learning patterns, and in particular, moving from whole genome bisulfite sequencing to a targeted methylation pattern, which would allow us to sequence more deeply and improve our sensitivity. In addition, we were able to utilize more cancer samples to train our cancer signal origin algorithm. And then in CCGA3, we had a validation of our Galleri test that would allow us to support our launch of Galleri in the summer of 2021. CCGA was a large study of over 15,000 participants. And in fact, we were able to collect blood from all individuals and collect tissue samples from the cancer individuals. This allowed us to do matched tissue and blood sequencing to help enrich our information, as well as to provide higher accuracy in the development of our machine learning classifiers. Importantly, we've been following all of these individuals up to 5 years. This has actually provided us with important information on outcomes, and we'll talk a little bit about the results of that analysis in just a moment. I mentioned to you earlier that we want to detect lethal cancers, and many of you, of course, are familiar with many of the lethal cancers that we think about. Those include, of course, lung, pancreas, ovary, gastric, and so forth. And so on the left, you can see 12 cancers that account for 2/3 of the US cancer deaths. And when we looked at the performance of our classifier in CCGA and focused on these 12 cancers, you can see that our sensitivity is 76% as compared to an overall sensitivity of 51%. This indicates that MCED testing, and in particular Galleri, is able to detect the cancers that we are really interested in being able to detect, because those are the ones for which we have the best hope of shifting the mortality curve. And so, as you might suspect, the sensitivity increases with stage, but even for stage 1 cancer, of these high mortality types of cancers, we had 37% sensitivity and 70% sensitivity for stage 2 for these cancers that we want to detect in the earlier stages. This is a busy plot of a cancer type by cancer type analysis of these 12 types of cancers. We won't obviously go into these in great detail, but you can see, for example, that we detected all of the stage 1 liver bile duct cancers. We detected half of the stage 1 ovarian cancers. And so this performance in stage 1 and 2 cancers should, in fact, be, and this is what underlied the more modeling that I showed you earlier, should have an impact on the stage distribution and therefore ultimately mortality from cancer. I mentioned to you that we were following individuals long-term for up to 5 years. This has actually told us a lot about the biology of the cancer signal. And in fact, what we can show is that there's an association with outcome of our cell-free nucleic acid signal that is detected by Galleri. So if we just focus on stage 4 as our first example, as you might suspect, stage 4 should have overall poor mortality. But what you can see is, in fact, that there are 2 broad classes of stage 4 cancers. In red are cancers that shed a lot of cell-free nucleic acid, and therefore ones that we can detect more readily. In blue are ones that do not shed as much cell-free nucleic acid or are less detectable. And you can see that they have a substantially better outcome than the high mortality shedding cancers. And in fact, if you walk back from stage 4 to stage 3 to stage 2 to stage 1, you can see that this principle occurs across all stages. And so what that's telling us is, in fact, that cell-free nucleic acid shedding is highly correlated with outcome. But that, in fact, if we can detect those in earlier stages, that we can improve the outcome. And so, in fact, stage 1 obviously has better outcomes than stage 2 and stage 3 and stage 4. So in our CCGA study, we were able to demonstrate that we had a very high positive predictive value. As you all know, positive predictive value is a fraction of cases that are called positive that are truly positive. And we modeled a 44% positive predictive value based on our CCGA performance applied to a SEER population. To put this in context, single cancer screening tends to have positive predictive values that are in the high single digits, somewhere between 6 and 10%. So the positive predictive value of Galleri is substantially higher, and this reflects the very low false positive rate. And so we've set a cutoff that gives us a very low false positive rate or very high specificity. And this allows us, in combination with the aggregate prevalence of multiple cancers, to achieve such a high positive predictive value. We were able to demonstrate that we had 41% sensitivity for stages 1 through 3 for all cancer types. But in fact, that sensitivity increased for these high mortality cancers, which are truly the cancers we want to detect. There's a concept of overdiagnosis in cancer screening, which you may be familiar with, in which there are various types of indolent cancers that we feel do not need to be detected in their early stages because they grow slowly and do not cause mortality. So this fact that we are able to have increased sensitivity for the more lethal cancers is a very important element of the performance characteristics of MSET testing that will be important when applied to a population. Lastly, we had a very high rate of cancer signal origin prediction of 89%. This will help physicians determine the types of workup that would be best suited for a specific cancer signal origin that they receive on their test report. As an example, if we return a result of cancer signal detected and accompanied by a cancer signal origin of colorectal cancer, it is very likely that they would do a colonoscopy. So I mentioned to you that CCGA was a case control study that was largely utilized to develop and validate our classifier. Of course, what we want to do is see how our test performs in action in real clinical practice. So Pathfinder is our implementation study, and we had an interim analysis that we reported last year, and now we're able to report the end of study results. Pathfinder was a prospective multi-center interventional return of results study. We enrolled from 7 participating institutions in the United States, and we had 2 cohorts, which we'll describe in greater detail. The enrolled participants answered some baseline questionnaires, and then their blood was drawn and shipped to our CAP-CLIA certified lab in Menlo Park, California. And generally, we were able to return results in less than 2 business weeks. And then those individuals receive a result. And there are 2 types of results that they would receive. The majority of individuals, of course, get a no signal detected result. In those cases, then those individuals are counseled to continue their guideline recommended screening. And then we follow those individuals for their cancer status at 12 months. The small proportion of individuals who did receive a signal detected result also received a cancer signal origin. That allowed the physicians to do their workup, and then the physicians would work up those individuals until they achieved something called diagnostic resolution, which was finding cancer or determining that they had done adequate workup and that there was no cancer present. Those individuals were also followed up for their cancer status at 12 months. As I mentioned to you, we had 2 cohorts. We had those that were only 50 years of age, but with no additional risk factors, and then 50 years of age or greater, and then with additional factors. And those additional risk factors could be smoking, so really any smoking, more than 100 lifetime cigarettes, genetic cancer predisposition, which was self-reported, or prior cancer history with treatment completed at least 3 years prior to enrollment. As you know, individuals with a past history of cancer are at risk for 2 kinds of events. One is, of course, a recurrence, and the second is a secondary primary cancer. And we were interested to see how Galleri could detect either or both of those types of outcomes. Our primary objective was really to understand what happens after a physician receives a test report that's cancer signal detected with accompanying cancer signal origin result. And so we wanted to understand the diagnostic pathways, such as their choice of imaging tests or invasive tests or laboratory tests. We also wanted to understand how long it would take for them to achieve diagnostic resolution. That is to say, how long it would take for them to find cancer or to decide that they were done with workup on individuals that did not have cancer. We obviously also want to understand test performance, and in particular, focusing on predictive value. And then we also collected a large battery of participant-reported outcomes to really understand satisfaction, anxiety, and health-related quality of life following MSET testing. I also want to point out that we had an early version of the MSET test that was utilized in Pathfinder, which was a little bit different from our current version called Galleri. And we'll talk a little bit about the differences between this early version and our refined Galleri version. So as you might suspect, our group with additional risk factors had more cancers than our group without additional risk factors. But I want to point you to the box in yellow where we report out the positive predictive value. And you can see on the right that our aggregate positive predictive value was 38%, very close to what we had modeled of 44%. And you can see that the positive predictive value is modestly higher in the additional risk factor than the without additional risk factor, largely because of the higher prevalence. You can also see in the gray box below that our cancer signal detected rate was about 1.4%. So all of these metrics, the cancer signal detected rate, as well as a positive predictive value, were in line with what we had modeled prior to going into the study. And in fact, the PPV, as you see here, of 38%, was much higher than the positive predictive value of the single cancer screening, as we had talked about earlier. This pointed to early signs that MCED testing was going to be a safe test to implement. Now, in terms of what its value was, we could show that we could double the number of cancers detected with standard of care screening. So if we take this population of 6,600 individuals and ask ourselves what fraction of cancers were detected by guideline recommended screening, and add to that the fraction of cancers that were detected by MCED testing, we could show that we could double that number. And in fact, close to half of the new cancers that were detected by MCED testing were stages 1 or 2, exactly what we hope to do when we are going to achieve a reduction in late stage cancer. As I mentioned to you, MCED testing appears to be safe with its high positive predictive value, but we also demonstrated that there were no adverse events due to diagnostic workup after a signal detected result. Now, interestingly, this study was conducted during COVID. Obviously, we could not have predicted that, but we in fact started enrollment in December of 2019. And of course, as everybody is aware, the world essentially went into lockdown in March of 2020. But we were able to still achieve effective diagnostic workup and in cancer diagnostic resolution. And so in fact, half of the individuals who did achieve a cancer diagnostic outcome were diagnosed with their cancer within 2 months. And 3/4 of those, 3/4 of the cancer individuals were fully worked up within 3 months. We were also able to demonstrate that our cancer signal origin result provided information that directed clinical workup. And so just to press on a couple of these issues, I wanted to demonstrate to you the MCED screening complementary to guideline recommended screening. So as I mentioned to you, we followed everybody up for 1 year. So at the end of 1 year, we could in fact look at who had cancer and who didn't. And this is the 121 participants who had a cancer diagnosis within 1 year. 60% of the individuals had cancer that was detected by some form of screening, which you see on the left. 29 of these individuals had guideline recommended screening detected cancers, while 35 had cancers that were detected by MCED testing. There was a small fraction of individuals who had their cancers detected by what we'll call non-standard screening, such as skin screening for melanoma or thyroid screening. So you can see here that MCED testing, in fact, detected more cancers than guideline recommended screening, which is exactly the outcome that we would hope to achieve using MCED testing as a complement to guideline recommended screening. As I mentioned to you, the workup was expedient even during COVID. And so here you can see our true positives were achieved diagnostic resolution. So that is to say a cancer diagnosis of 57 days was the median. And then as I indicated to you earlier, that 73% of their true positives achieved diagnostic resolution in less than 3 months. As you might suspect, false positives took somewhat longer to achieve diagnostic resolutions. Most of these individuals actually had planned reevaluation. That is to say, a physician would do an initial workup and then decide that they might wait 3 months or 6 months to do a follow-up imaging just to confirm the absence of a cancer. So you can see that in aggregate, the median time to diagnostic resolution of when taking into consideration both true positives and false positives was 79 days. I told you a little bit about our goal to understand the types of workup that individuals underwent. And the findings are very logical. That is to say that almost everybody got an imaging procedure. So whether they had cancer or whether they did not have cancer, over 90% of those individuals had an imaging procedure. And most of these imaging procedures were modalities such as CT, MRI, or PET. The big difference between true positives and false positives comes under invasive procedures. You can see that 82% of individuals who did have a cancer diagnosis at resolution had an invasive procedure, whereas only 30% of individuals who did not have cancer at diagnostic resolution had an invasive procedure. This is quite logical in the context that we would expect that individuals with cancer would need procedures such as biopsies or other types of confirmatory procedures, whereas individuals who did not have cancer would not need those because most of those had imaging as their first-line procedures. There are a handful of cancer signal origins which naturally lend themselves to invasive procedures as the first workup, such as colorectal cancer signal origin would lead to colonoscopy, head and neck might lead to laryngoscopy, and so forth. And so this outcome of invasive procedures being heavily weighted toward individuals with cancer, and in fact, most individuals who do not have cancer can avoid an invasive procedure, again, speaks to the safety of MCED testing. Let's get this. So of course, what we want to understand is the types of cancers that were identified in this population. And you can see on the left, there were 18 participants who had 19 tumors. So in fact, one person had 2 cancers. That was a woman who had breast and endometrial cancers. And then 17 individuals had hematologic malignancies. If we look at the names of the cancers on the solid tumors, you can see the ones that we are very interested in detecting. For example, pancreatic cancer, liver cancer, lung cancer. And these are ones that obviously complement guideline recommended screening. In fact, this lung cancer that was detected was an individual who did not qualify for USPSTF guideline recommended screening for lung cancer. As I indicated to you earlier, almost half of the individuals had stage 1 or 2 cancer, and 71% of these cancers that we identified were ones for which there is no standard screening. Again, demonstrating the clinical value of layering MCED testing on top of guideline recommended screening. As I mentioned to you, there were no adverse events in this study related to the workup, again, pointing to the safety of MCED testing. So I mentioned to you earlier that we have updated our MCED test from this early version to the current version that we call Galleri. And this current version has an increased specificity threshold for heme signals so that we reduce the calling of monoclonal B-cell lymphocytosis and monoclonal gammopathy of unknown significance, so MGUS or MBL. We also removed indeterminate as a cancer signal origin, thus helping physicians have a better idea of what type of cancer signal that they should work up. I'm just, in the interest of time, we'll just continue. So I just want to point out that when we look at this new version of the test compared to the version that was returned in Pathfinder, the outcome was exactly as we had expected, which is to say that we increased our specificity from 99.1 to 99.5%. And in fact, this higher specificity reveals itself in a higher positive predictive value, namely 38% to 43%. And you recall that our modeled PPV was 44%. And so in fact, the test was behaving in real life very similar to what we would have expected based on our modeling results. And this again was confirmatory of our belief that the MCED test was going to be both valuable and useful in the clinical setting. So this summarizes the results of the refined Galleri version of the test. Again, I want to point out 99.5% specificity, leading to a 43% positive predictive value. Again, very high cancer signal origin. And again, the ability to detect a large number of non-distant metastatic disease. So as I mentioned, Galleri is now our test for MCED testing in a screening population. We launched it in summer of 2021. And we have now offered more than 35,000 tests in clinical use. We've been able to demonstrate that we can return results in a timely manner, and we can help detect cancers that lack recommended screening. And in particular, because this is changing the paradigm of cancer screening, we have a substantial amount of post-positive test clinical support to help physicians navigate through the process of working up individuals with a cancer signal detected result. So if we just focus first on the right, actually, you can see that we have a high rate of return of results, 99%, with a very quick turnaround. It's in fact faster than what we had in Pathfinder, as we have developed and streamlined our workflow. We have a large clinical laboratory in Research Triangle Park. And then you can see that 98.4% of test results are delivered within 10 business days. If you look on the left, the results are very similar to what we had seen in our Pathfinder study. So 1.1% of test results are cancer signal detected. Those are accompanied by 1 or 2 cancer signal origin results. And so those cancer signal origin results are provided to the physician to help them determine their best course of action. These are the important safety information and laboratory test information. And again, just to highlight that this is a test for individuals with an elevated risk for cancer. And of course, we all know that age is is one of the most important risk factors for cancer. It's also not intended for individuals who are pregnant or in the pediatric population or individuals who are undergoing active cancer treatment. And of course, the test needs to be ordered by a physician. So I'd like to thank you for your time. I hope that I've been able to demonstrate to you the biology of cell-free nucleic acid testing and how that biology has told us that there's a shared cancer signal, and that we are able to detect that shared cancer signal, as well as utilize methylation patterns to identify a cancer signal origin. I've also demonstrated to you that we have a very large clinical development program that has started with discovery, validation, and now actual use in clinical practice. And over time, as we develop more population-based data, we'll be able to transition from these small studies into, for example, our 140,000 person randomized control trial within NHS Galleri, our 20,000 person Pathfinder 2 study, and start looking at utility metrics such as a reduction in late stage cancer diagnosis. And with that as a backdrop, then we hope that ultimately we will change the conversation around cancer screening to multi-cancer screening, which will have ultimately the best outcomes for our patients. And thank you for your attention. So I do have a few questions, and I'll address them one by one. So one question was, how many of our invasive procedures were diagnostic versus therapeutic in Pathfinder? So of course, the individuals who did have cancer were then referred for therapeutic treatment, and some of those were surgery, some of those were chemotherapy, and so forth. What we were largely capturing were the diagnostic procedures, so FNAs, core needle biopsies, or other procedures that were utilized to confirm the diagnosis. Are the demographics of the Pathfinder study population different from other studies evaluating single cancer screening tests? That is a really good question. As you know, there are 2 phenomena of many cancer screening tests. One is, of course, what we call a healthy volunteer bias. So generally speaking, there's a population of individuals who are heavily engaged with the healthcare system, very proactive about their health, and very curious about new technologies. And so they are more likely to enroll in studies. And if we look at, for example, large screening trials such as PLCO or NLST, one of the striking characteristics is that they tend to be a fairly homogeneous population. And Pathfinder's demographics were largely aligned with these studies such as PLCO or NLST. I mentioned to you that Pathfinder 2 has a very dedicated effort to increase the diversity. And so in Pathfinder 2, we're working with institutions that have a demographic that is much more diverse and often the underserved population. And it's our goal to work with these institutions to increase the enrollment of a broader, more diverse population to demonstrate the performance and clinical value of MCED testing in these populations. A third question is, can you explain how this early MSED test doubled the amount of cancers detected? Yes. So as I indicated, in this population of 6,600 individuals, we followed all these individuals for up to 1 year after enrollment. And and so we also asked if an individual had a cancer diagnosis at that time. We asked how that cancer was detected. And a fair number of those individuals has cancers detected because they were undergoing surveillance. For example, they might have had a previous finding, or they might have had a previous cancer and they were undergoing routine or interval imaging, for example, or others had signs or symptoms. But there was another group of individuals who are coming in for their annual mammography or their colonoscopy that they were due, which we generally have either 5 or 10 years, depending on an individual's risk factors. And so we counted that number, and the number of individuals who got their cancer detected by guideline recommended screening was 29. As we indicated earlier, MSED testing detected 35 cancers. And so MSED, of course, is a form of screening. So you can see that MSED testing detected 35 cancers, guideline recommended screening detected 29. So that's clearly more than the number, MSED testing detected more than the number of guideline recommended screening. So that answers the question about doubling the amount of cancers detected. How does someone get a Galleri test, and is it prescribed? So as I indicated to you, Galleri test is by prescription. We have a website called galleri.com. So it's just galleri.com, and there's information there. Can the Galleri test actually make a difference in patient outcomes given the stage 1 sensitivity? So in fact, yes, and we demonstrated this largely by modeling, because obviously to look at outcomes, we need multi-year follow-up. If we think about the outcomes that we're very interested in, we have to think first about a shift from late stage detection to early stage detection. We got a hint of that in Pathfinder, right? Close to half of the cancers that we detected that were new cancers were stage 1 or 2. So we are detecting early stage disease out in the real clinical world. The NHS Galleri study, the 140,000 person RCT, is going to actually have enough sample size to actually demonstrate a reduction in late stage cancer. The other element too is that the cancers we're detecting are ones that tend to be highly lethal, such as, and you saw in Pathfinder, we detected lung, liver, pancreas, and so forth. And so if we can detect those in stage 1 or 2, they will certainly have, at a population level, better outcomes than individuals who are today detected principally in stages 3 and 4. Who do you see ordering these tests in the future in the clinical setting, the PCP or the oncologist? So typically, screening is done at the PCP level. And so generally speaking, we would see this as a complement to guideline recommended screening. And so those individuals who are coming in for their annual mammography, annual mammogram, or their on-time colonoscopy, or even their low-dose CT, if they happen to be a high-risk smoker, those are typically done out in the PCP level. And the PCP might have a conversation as to whether that person would derive value from potentially multi-cancer early detection testing. Next question, of the 6,600 participants, did all get routine screening tests like mammo, et cetera, as per their age, gender indications? And was the MSED being compared to a group that was heavily engaged in routine screening tests already? The answer to that, and the two questions are related but not identical questions. So on the second one, was MSED being compared to a group that was heavily engaged in routine screening tests? The answer to that is yes. So it was being conducted in a group that was heavily engaged with routine screening. The best example of that was when the Pathfinder participants, being up to date with colorectal cancer screening was over 80%. And in the general population, that number is more like in the 60s. So already highly engaged with their screening requirements. The first question, did all get routine screening tests like mammo, et cetera, as per their age, gender indications? So we did not mandate, for example, a side-by-side screening. What we did ask was, have you been getting your screening? We asked that actually at the beginning of the study and at the end of the study. One of the reasons we asked this both at the beginning and at the end of the study was because we wanted to see if MCED testing changed people's behavior. And what we were able to demonstrate was that, as I said earlier, this was a heavily screening engaged population, and that there was no real difference in their screening behavior after the MCED test. So I think we have hit both the end of the questions as well as the end of our allotted time. So I want to thank everyone for their attendance, and really appreciate your spending some time today to learn more about multi-cancer early detection, Galleri, and how they are positioned to help patients and ultimately at a public health level complement guideline recommended screening and decrease the overall burden from cancer. Thank you very much.